and that is the topic of enuresis. I had mentioned earlier that in the 1950s or so there was no outcome study. It turns out there was one, and that was by Maurer and Maurer. And that was a development of what you probably know as the urine sensing alarm. And it was based on a Pavlovian theory that somehow or other the sound of the alarm would be associated with the relaxation of the sphincter muscles in the bladder. I never could understand what that meant. Does that mean that whenever you heard the buzzer, you would urinate? In any case, that was the theory behind it. It's very widely used and been experimentally validated by dozens of studies. It still is considered to be the most effective in terms of the empirical validation of all of the methods of controlling nocturnal enuresis, including all of these current miracle drugs that have been developed for that. You can buy it from any of the mail-order companies and departments. And so I tried it. I had occasion to work on the problem of nocturnal enuresis by virtue of the fact that the retarded individuals that we had on the ward when the hospital converted over to retarded, that enuresis was the rule rather than the exception. And so that seemed like a piece of cake. I'll just take the Maurer procedure and try it out and order a large number of samples of the urine alarm system and had instructions in it, tried it out. And there was another example where it didn't work on any of them. Nothing. The alarm went off. There's a urinated. The alarm went off. They slept right through it. And so there we go again. And if you look at, well, so it was pretty clear though, it was quite aside from Maurer's original article, which had no control group, didn't even have numbers in it, didn't say how many subjects, didn't say how he evaluated it. But still, there was a large number of replications of that that showed very definitively that that method does work and very, very well. So it seemed clear that it was because of dealing with retarded individuals that they had no concern about the alarm going off and slept right through it, which led to, again, an entirely different conceptual reappraisal of what is going on. Why does the urine alarm normally work? Why didn't it work in this case? And coming up with some possible explanation, what could be done about it? And so I came up with an entirely different explanation, that it wasn't Pavlovian conditioning. I couldn't understand how Pavlovian conditioning could do it anyhow. But it did work. And so conceptually, I think, well, sleep is reinforcing. We had a busy day, sleep is reinforcing. If you look at it that way, then what is it that's aversive? It's being awakened, especially in the middle of the night. The alarm goes off, it awakens you, and it's the urination that caused it, that is the relaxation of the muscles in the bladder. And so, looking at it that way, it says that it's an operant. It's not Pavlovian conditioning, it's an operant. And if it's an operant, then it says something else is very important, and how can we maximize that, and how can we do it in such a way that now will be operative and beneficial for the retarded as well. And so, the simple solution was that when the alarm went off, that you would awaken the resident. Awaken, and of course not just awaken so that they opened up their eyes, but really awaken. And then some of the other things that we had talked about, that if they are awakened, use some of the other procedures we talked about that have been developed in other concepts, and the concept of correction, that you ask them to assist to the extent they could in remaking the bed, putting dry sheets on, and then the positive practice, giving them practice in going to the bathroom as the alternative, constructive, correct response. Poof. And it worked. It was wonderful. And rapidly, right? The Maurer procedure usually took a couple of weeks before it was effective, and this thing it was effective within a few days. Well, if it works with retarded, then what about not to go through the same kind of logic we saw with regard to the toilet training, having found something that works so well with retarded, how will it work with normals? So I tried it out with normals, and again obtained families in which they had a child that was anoretic, that was in bedwetting, and tried it out with them, and it was similarly effective. And it went public, and all these things, these are published, I'm not making up these stories. And it worked. And then I said, well, okay, I'm going to carry this even further. And if it's the awakening that's important, and not the Pavlovian conditioning, then it's not necessary that the child even hear the buzzer. And so I hooked up a long wire that went from the apparatus to the urine sensing pad, and instead of going to a buzzer that was right next to the bed, had it connected, go all the way to where the parents' bedroom was. So the buzzer went off in the parents' bedroom. The child never heard it. And of course, at the time that the parents heard it, they were instructed to now awaken the child and to go through the other procedure, having the child remain in bed. And that worked. So it's an operant. It's not Pavlovian conditioning. It's an operant, and it'll work even with the developmentally disabled if you treat it like an operant and not like Pavlovian, then all you need is the association of the buzzer and the urination. So there's another example of trying something that conceptually in the basis of the literature should work. It didn't work at all. Find a solution to it, and do a conceptual analysis first, to come up with a solution on it, because there's no literature on it. If you try to find a literature on treating aneurysms with retarded, it's non-existent, just as in the other area. So that's an alternative, and studies have been done comparing that method now with the urine alarm with normals, and it looks as if they're about comparable in effectiveness. The difference is really being in terms of time and expense. In terms of expense, this method does not require you to have this, well, I tried it without the alarm there at all, just awakening, that you just manually had the parents inspect it. I missed that. They had the parents just inspect the bed periodically during the night at times that were convenient to them. They knew when they first got up in the morning or at the time they went to bed. And at that time, if the bed wasn't wet, then to awaken the child and have the child correct it and to do the overcorrection and the positive practice. And that worked. And the studies have been done now. And I wrote a book on that too. Right? Again, if something works, then give the details. And so I wrote a book on that called Parents' Guide to Bed Wetting Control. And many studies were done by others, comparing the urine alarm with this other method, which I euphemistically call the dry beds method, and they're comparable effectiveness. Fortunately, they're not mutually exclusive. You can use both at the same time. You can have the urine alarm in there, and then also do the parental awakening and the positive practice and all the other. So that was still another area. Okay, let's see. Maybe I'll try to go through those that seem. Let's see. Which ones do next here? We did the marital, the job club, in terms of the insomnia is one. Let's see. Tourette. Yeah, because I see some people in the audience here who work on that problem. There is a problem called Tourette. It's considered to be a neurological problem, and I think that's largely correct. What it consists of is the individual having multiple tics. Tics meaning these nervous types of spasms. It could be a shoulder jerk, and that has a name. It could be this kind of thing that has a name called torticollis. It could be, as you see with young children, especially facial. It looks something like this. It could be eye tick, it could be eye blink, it could be the nose. It can even take rather massive forms. It might even be a pelvic thrust kind of thing where you tie your muscles, arm flapping, you name it. You name any bizarre movements in any part of the body, and it can occur. And if it occurs only as that one type of tic, then it's called, in the DSM classification system, it's called a single tic. And it can occur either as a motor tic, or it occurs a vocal tic. Vocal tics most commonly are coughs. Or it could even be nasal, and that is a nasal. It could be the nasal snort, or it's nasal sniff, the sniff or the snort. And these things, everyone does these, some of these things occasionally, could do them. But individuals who have these problems, for which have this irresistible urge, it comes over them, it seems to be neurological, and they can't stop from doing it. It'll just keep on happening. If it occurs, if there's a vocal tic in combination with the motor tics, then it's given another classification clinically, and then it's Tourette disorder. And that's been given a good deal of publicity, in that the vocal part of it may involve uttering some obscenities, so that individuals that never have heard this, this be adults as well as children, have never been heard to utter any obscenities, suddenly will blurt it out. You're not in a functional way. They'll be talking about something, and then all of a sudden, and they'll let out full letter words, and blast it out very suddenly, and then continue what they were doing afterward. And it's almost like a muscle twitch. So what to do about that? Some of the procedures the general procedures I talked about were brought to bear here, that correction principle that I talked to you about when self-stimulation, that's how I started working on this problem. There was a fellow in the mental hospital who was actually in the alcohol program, and we weren't treating him for alcoholism, but he was in the program, and he had this twitch, and torticollis it's called, and if it repeats, if it's static, chronic, then it's like this. And then they're looking at you through the corner of their eye, but the head's twisted, it stays that way. Or it could be that it's spastic, and that is it's a repeated twitch, like this. And what to do about that? Well, he wasn't asking for help. We just happened to see him walking around with this problem, and we were working with people in the alcohol program, and so it looked as if it had some vague resemblance to what I was working on with self-stimulation with the retarded, that it engaged in this movement, except in the case of the self-stimulation, people are obviously doing this in a voluntary way, but this other was a jerk. Well, still, I took the simple-minded conceptualization. I'll try the same thing out on that and see if it works. And so, and the procedure that I worked with the self-stimulation was to go into identify a competing, alternative, antithetical response. And there were several requirements on that. It wasn't just find something that was antithetical, but it had to be antithetical, that you couldn't possibly have the tic while you're engaging in that competing response. Secondly, it had to look very normal, so you couldn't have a tic in the other direction. You couldn't have it antithetical. And it had to be something that you could engage in normally without disrupting other activities. The rationale for that being that if it was something that would disrupt other activities, then you're not likely to do it. So it had these other stringent requirements. Well, so that particular case with the torticollis had him tighten the muscles that would keep the head straight. And when you did your, to bring that down, and more important, to do that as soon as possible. Not wait until he actually had the tic, but as soon as he felt that he was about to have it, and he felt a slight movement, immediately do it, and even better, do it when he had even the sensation, or the thought, or whatever. And if you ask people, what is the precursor, is what I call it, they often say, well, I can't really say it. So the feeling, that's fine. As long as you can identify that feeling, and as soon as you feel that, then immediately you lock those muscles in there and tighten them just enough to block the thing. And the critical question always is, okay, now that you're doing that competing response, what we consider to be a competing response, I want you to deliberately try to perform that tic. And when they say, I can't, that's it. We've got it. Now it's just a matter of generalization and maintenance. And it's lots of fun. Everybody has a different kind of tics. I have more fun when people come in with tics, trying to figure out what the antithetical response would be. And I always do that by having them engage and say, I'm going to mimic you, but I'm not making fun of you. I'm going to do what you're doing and tell me when it looks about right, the same as what you do. And then when I do that, I start playing around with different postures and movements and to see what I'm inhibited. And then I say, this worked for me, now let me see you try it. And as often as not, I'll say, yeah, it doesn't work for me too. So then that's the assignment, that we practice it in the session, doing that, and the assignment. It was a therapy session, and if there is a significant other, either a spouse or a family member or a parent or someone else in the family, have them oversee it and to give reminders. And again, significant others being brought into bear. You don't just pray for generalization, you arrange generalization so that you have the reminders and the reinforcement. And you see the person going for without the tick, praise them. And so always praise the absence of the response, always praise them when you see the intensity. Well, that's the tick. So then what happened is I applied it down to different kinds of ticks and published several articles on using not only the muscular ticks, but also did it on these oral ticks where individuals do strange things inside of their mouth. They suck on their gums, or tongue thrusting, or gum thrusting, kinds of things that you don't even notice. And tried it out and published on a large number of different kinds of ticks and other things that come under the heading, I guess, more on habits. And the ultimate, of course, was doing it on Tourette, because Tourette is considered classically, and as I say, largely correctly, as a neurological disorder. So what in the world are you doing as a psychologist trying to achieve a neurological disorder? Well, it turns out happily that it works. And the one on the vocal part is, you think, well, that might be the hardest one, because it's Tourette. That's the easiest one, because I analyze the data on that, and what happens, how much of a decrease you get with this procedure on the vocal as opposed to the motor, and both of them is approximately 100%. And it's no less for the vocal. The vocal is much easier. It turns out it's an easier thing to do. In general, what the procedure consists of for almost all of the vocal is not only identifying what the internal muscles are, but relaxing them. More important, smooth, uninterrupted breathing. And I tell them, okay, now do it. I'm going to do it with you, because I did it first to see if it works. And then now deliberately try to engage in that tick, while still keeping that air moving. You say, I can't. That's it. You can't. Now it's a matter of having that come on. And by reacting to the initial part of it, just the feeling, just the sensation, it never occurs. They're preventing it before it gets started, and it's not a matter of going through life having to engage in the competing response. Because as soon as anything remotely resembling that feeling comes into play, it prevents it, and you have them engage in it for roughly 2 minutes. And why 2 minutes? Because these tics tend to occur in a flurry that is in rapid succession, so when you do it for 2 minutes, it makes sure that nothing's going to happen in the next 2 minutes, but more than that. What it's doing is it's giving extensive practice in the positive competing response. And so that works very, very well. And there's at least one member of the audience there who has worked on this repeatedly and simplified the procedure. I had a large number of steps on there, but the principal ones I just mentioned. Okay, let me take another one that's very common. This is the most common problem that there is next to many reasons, next to toilet training, and even more, and probably as common as marital counseling. There's nail biting. Extensive research has been done by the non-treatment folks talking about the incidence of nail biting, and it turns out that over 50% of the population has been, is, or shortly will be, an assiduous nail biter. Which means, if the definition of normalcy is being something other than that, it means if you're not a nail biter, you're abnormal. There was one study that was done previously. It was called negative practice, and that resulted in something like a 50% reduction in the nail biting. I took that same procedure here called a habit reversal, what I use for the tics. So what is the antithesis? What is the competing reaction for nail biting? And the thing is, do something else with your hands, right? In order to nail bite, it's got to come up to your mouth. So the first thing is don't let your hands go above your shoulders, right? And secondly, get your hands busy doing something else. It's not a matter of don't, it's always do. What is the positive response? Do. So whatever you're doing, you're driving a car, hold the wheel with both hands, you're reading a book, then hold both sides of the book. You're watching television, hold the armrest with one hand, hold the remote with the other, or the cushion. But continue what you're doing. Don't interrupt anything. If you're writing, if you don't have a typewriter, you're actually writing, and the pen is doing something, and then press down on the sheet with the and then and there are a couple of other little twists on it, and it works beautifully. We put an ad in the paper up, I was issued in Carbondale. There aren't too many people there, so I put an ad in there about ticks, and all the farmer wrote down and said, what kind of an insect is this? But aside from that bit of humor, I wanted many subjects on these things, and when I couldn't get them from a small college town, so I had my counselors go up to Chicago, and they put an ad in the paper, and I think half of the city of Chicago turned out. We were using the local mental health center as the office, and they complained that no mental health, no people could get through to the telephone because the phones were tied up completely when people called. And so I did a study on it. It was a very large sample. I actually did it in groups because there were so many people, and you could teach the people to do it in groups. And to me, it gets rid of it. It gets rid of the nail biting. And it's the most common problem that there is. It's a very simple solution. It's easy to do. Yes, Brad?
HBO just had a special with Tourette's, children that have Tourette's, and it was fascinating because out of the whole series that they didn't have one intervention approach that they had even shown. It was really deplorable, but it was a nice, it was a nice special that they had as far as showing what it looks like and so forth. But it was just fascinating that for whatever reason they weren't aware of any treatments.
When someone comes in with Tourette, right, it's great, right? I was talking to my wife. My wife and I work together on the outpatient basis. Yeah, we know. Yeah, and sometimes it's almost humorous. We work with the child alone, and the parents outside, and the parents come in and say, "What did you do to him?" No, Daddy did you beforehand. They're twitching and turning, and then they've been to all of the clinics in the country. They've been, some of them are physicians themselves. And then they come in 1 hour, what did we do? I mean, he's not showing anything. No, it's so dramatic. It just, there are some things that happen immediately. That's one of them. The other one is stuttering, where people come in and they can't get a word out edgewise. And within 1 hour, they're talking to you and telling you about all of their life, and there's no blockage at all. And you teach the competing response, and the same thing. Say, now when you're doing that competing response, I want you to deliberately stutter. And I give a dictionary, because they always stutter on V or T or whatever it is. And, okay, now read the words down the list, and they go, blah, 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 blah. No stutter. Beforehand, they go, blah, 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 and they can't get to the second word. So it's very dramatic. I mean, you're dealing with something else like, depression or a job. I mean, you're waiting weeks or days or months, before you see anything. But those problems, it's very fast. And it's almost like working with the retarded. You have an intensive session there, and it's so gratifying that at the end of that day, there's a change. There's a change that somebody's been suffering from 20 years, 30 years. And in the case of nail biting, that may seem trivial, but the people who have it, many of them is bleeding and they're scarring. Others, they always keep their hands in their pocket. If they're at a table, they keep their hands under there. They'll never put jewelry on because it draws attention to their hands. And so it's like every other disorder. It only seems humorous if you don't have it. Right? If you do, it's it. And some recent studies that I guess you and your colleagues have done talking about some of the correlates of these things are just astonishing. There's a degree of unemployment and adult disorders and alcoholism and others that go along, and divorce to individuals who suffer from these things. It sounds like a simple thing to tick, but the social consequences can be very, very, very drastic. We're making incredible headway here. Let's see, the other program, another one here is, actually getting to some of the alcoholism. Of course, the primary method of dealing with alcoholism is to call the AA, not the AAA, that's the towing company, but called the Alcoholics Anonymous. And they are so dominant that they are very strongly anti-professional, not only with regard to behavioral psychology, but to medicine. They just don't believe medicine. It's almost a religion. In terms of outcome studies are on them. I tried to do one and was immediately told, well, no, I couldn't do it because what I wanted is follow-up data. And they won't give me their names. It's Alcoholics Anonymous, right? So you can't have their names. And he says, and Al wouldn't let you. I said, well, wait a minute, what do you mean Al? How do you know his name? so the anonymous part, apparently they pull out when it suits their convenience. But in any case, there are no outcome studies of Alcoholics Anonymous simply for that reason. And it sounds like, do the validity test Protestantism or something. It's obviously true. Well, there are several medications that have been tried for that. One of the most dramatic ones is this medication called Antabuse. That's the trade name. It's disulfiram. And it almost seems to be the answer to alcoholism. It was apparently found in Scandinavia in the process of they're using their drug to teach some other disorder, and the people came in were given it, came back and said, it's great, but I can't drink anymore. When I drink alcohol, it makes me sick. And they try different kinds of alcohol, it doesn't make any difference. It's dose response specific, and that is, if you take a large amount of alcohol, then you'll have a more severe response. If you take a large amount of the disulfiram, you'll have a more severe response. And it's taken in the form of a pill, and it has slightly metallic taste to it. What it does is, if you take alcohol any time after that, then you become all flushed, and your heart beats faster, you feel very uncomfortable and somewhat nauseous. And it will react, again, people differ, but it's dose response specific. For some individuals, if they're taking it, then even if they use an aftershave lotion, they don't drink it, it's an aftershave lotion, it's alcohol, so it'll make them ill. But others, it takes a much larger amount, and it depends how long it is. And obviously, if people don't want to be dry, they just won't take it. It's one of those drugs that it really depends on whether you want to be free of alcoholism. And it's very difficult to find physicians who will prescribe it, because it's one of the few drugs that's designed to make you sick. And many physicians will not prescribe it if they feel that it will make the person ill. When I was in Southern Illinois at first, started using that drug. We were rather fortunate. I was given control of an alcohol treatment unit, and we had a physician there that was very, very cooperative. When I moved to Fort Lauderdale, there was an existing alcohol treatment unit, the county alcohol treatment unit, and the MD that was in charge there, he routinely used disulfiram. So it definitely differs enormously. I did several studies without that. I developed a procedure that has been called, since I named it that, the community reinforcement method. And the basic rationale of that is competing behavior. And the conceptual analysis was analyzing why is it that people become alcoholic. And I said, well, several reasons, honestly. One of them is that it's addictive. That means that once you drink it, it has this characteristic that it takes more and more of the same quantity, takes more and more quantity to produce the same psychological effect. It feels good, right, as the analyst put it. It's that the superego is alcohol soluble. It gets rid of your conscience, and you do all kinds of stuff that you wouldn't dare do otherwise. It tastes good, and the manufacturers, they go to great lengths with their liqueurs and others to go and to give it a very distinctive flavor. Your white wine and red wine and the liqueurs come in infinite quantity. And if you stop drinking, then you go through withdrawal, which is a physiological reaction, and you're very, very uncomfortable. And so there are all of these sources of strength of that. Not only that, but it's part of the culture. If you live in France and you don't drink, then you are an anomaly. If you go to any party or any social event and don't drink, then you're considered to be a variant in the culture. The people who work with briefcases in them, not because they have papers in them, they have a pint of liquor, which they're using during lunch. If you go into a restaurant and order a Coke, or say, I'll take either Coke or a glass of wine, whichever you want, they say, well, the wine is cheaper. And it is. The wine is cheaper than that. And routinely, people have to take a pint a day, and that's considered to be a normal amount. So it's culture. So all these reasons now, taste, right? The adverse effects of stopping, it's a tranquilizer in a way, it's a psychotropic drug. social influences. So the question is now not why is it that people, as the way I analyze it, is why is it that people become addicted? Is why isn't everybody? Why aren't we all addicted? I mean, it tastes good, it's inexpensive. You go to a cocktail party, you have to have a cocktail, or at least pretend that you don't have it. If you're watching a football game or going fishing with your buddy, you have to have a beer. So it's socially mandated, it tastes good, there are withdrawal symptoms of it. So why isn't everybody? And the answer to that, for me, was this conceptual analysis, was it interferes with things. That when you drink enough alcohol, that it'll interfere with your work. And contrary to public opinion, it interferes with sexual arousal, that in treating alcoholics after a while, and it's not uncommon for the wife to say with a male alcoholic that we haven't had sex for years, that it reduces sexual desire. It interferes with your work. You'll have a DUI if you're doing it while you're driving. There's scarcely any job anywhere that will allow you to be under the influence of alcohol while you're working, even if you're a bartender. And because it does interfere with functioning. So what does that suggest as possible treatment? To increase these competing responses. And so, what kind of things will interfere with it? A job. Well, we're back to the job code, right? You have a job, and it has to be a particular kind of a job, and preferably one that is year-long, and it's not temporary, and that it's not part-time, and that's why people who are ag farmers, they get drunk in the off-season after the harvest, and actors, they get drunk, and after the picture is finished, and house painters, they get drunk after they finish the house. So what you want occupations in which they are enduring, and in which you cannot take voluntary interruptions. And then marital, and that is a significant other who suffers from that, and that is whether it's a legal marriage or otherwise, but that somebody will suffer when you become incapacitated. And so what it suggests is doing marital counseling as part of the alcohol treatment. That's why community reinforcement. You want to bring the resources of the community to bear. Also, there are many situations in which alcoholism is not tolerated. For example, in religious in temples or churches, they don't talk. Your in-laws, right? They're justified in being opposed to the marriage. So there are many clubs and associations that you go to. There are certain groups that are temperate, who will not drink. So increasing those associations. And so when that's suggested, if we can make it as we do, make up a list of people who allow drinking, who are what we call risky, to have to call them risky people, and others safe, other people who do not drink, and try to arrange their life schedules so that they will spend more time in the safe people in the safe column and less in the risky column. And so that's one, and there's peers, associations, and then marriage, vocational interest. And so build up all these competing reactions. And if you do have to drink and you have a significant other, then having a significant other coming with you, because that would be an automatic inhibition, because that significant other is knowing that they're going to be at risk, that you're going to sell the farm, the house will burn down, you give away all the money. And so that's the community reinforcement approach. There's building up all of these things, and then some new studies have been done by others. They've tried doing alcohol counseling with and without randomly assigning people to either receiving marital or not receiving marital concurrent with the alcohol counseling, and find there's very substantially increased benefit when they do the marital along with it. All right, so I was promoting marriage as a therapy for something else, right? Before we talked about jobs as being a therapy for other things. And so it's an entirely different way of thinking about it. But then that's what that conceptual analysis does. And so I've done studies, several studies with that, doing that type of alcoholism treatment. And it's still nowhere near as popular as AA. Nothing is. People all go to AA first. Even hospitals that have a medical model and they treat them with drugs, and they'll have an AA unit right on the ward there with them. It's so popular. But again, we're not talking about marketing, we're talking about efficacy. What is it that really will work? Yes?
AA, most of this stuff is just like a hocus pocus, like a little stuff. But the big thing I think that makes AA work is that it's powerful social reinforcement. It's majorly operative. You walk through the door and people say, we love you. You know, you stand up and make a speech and everybody tells you how wonderful you are.
You're saying that one of the reasons why being employed as a remedy for someone who's alcoholic is that all of the social approval and self-esteem that they obtain, absolutely.
Yeah,
right. Yeah, and employment by definition means you're being paid. Right? So if the sobriety is associated with that, then fine. Well, and there's no reason, and so yeah, your point is, and that was the question, is perhaps the reason why the job is so effective is because of all the reinforcements that are associated with the job. There's not only the social, but as I say, also the obviously the remunerative part of it. Well, so all of those factors then, and I know it's for individuals who are really far gone on this, even adopting a dog, a pet, somebody who will suffer when you are drunk and can't function, right? That dog will suffer, and so having a pet, having any animal, anything that will do it. And when people hit bottom, though, as it's called in the field, and that is that they've lost everything. They've lost their money, they lost their home, they lost their family. Then, of course, you have to have special priming types of measures to get them started again, which means having them find a place to live and using some small funds to have them be able to subscribe to a newspaper so they can find out what events to go to. You can't drink and be in a movie, and you can't drink at other kinds of social events, and so find out what other activities that they can engage in. So that's the community reinforcement, and that's something that I originated, but it's not caught on at all. It's very time consuming. You have to do marital counseling, you have to do job counseling, you have to do daily planning with them in terms of their activity. It's very time consuming, and if there are any clubs or organizations you can belong to that don't ordinarily, where you don't drink, then encouraging in that. So what you're using is principles of stimulus control, which situations are associated with drinking versus no drinking, and then incompatible responses, finding significant others that are going to increasing the influence of them through the marital counseling. They'll naturally exert their influences to decrease the drinking on the part of the individual. And so that's the essence, the principal aspects. There are many other small details, but that's the conceptualization part of it. I tried that out in several studies, I say, and it does work. It does decrease. It works. And tried some with and without the anti-abuse. And the anti-abuse combined with it is just wonderful. Without it, it isn't. And the anti-abuse by itself, without this other type of counseling, doesn't do anything. What happens is they run out of their 30-day prescription and they don't even bother refilling it. But the combination is wonderful because then you have the spouse, the member of the family now, that will encourage the individual to take the anti-abuse every day. It does last a few days, depends on how much anti-abuse they're taking. But the two combinations will do it. Well, let's see. We have, here in terms of the drug addiction, this thing Brad, Donnie, you and I have been involved in. We have large federal grants, several from National Institutes of Drug Abuse to use these behavioral youth programs with youth. These are youth who have drug problems, that they suffer from substance dependence, and also from conduct disorder. That is, that they were problems. They were behavior problems in the community or in the home. And the procedures there were somewhat a mixture of some of the other procedures that we talked about. And that is, you do contracting between the parents and the phrase that's used on that is family behavior counseling, that the family is very heavily involved. And so you work with the parents, the parents accompany the youth when they come in, which is often the case because they usually don't have transportation. And you do these procedures we talked about with regard to the marital counseling, and that is you teach them how you draw up a contract between them. It's unlike the token economy, where the token economy is pretty much imposed. In behavioral contracting, it's all negotiation, that each one asks for what they want, and the other will either agree or ask for modifications, and then you have a formal contract. And what you do is try to build up the positive behaviors that they will attend, and not so much don't do, but what to do. And that is, they will do chores, keep them busy, they will associate with particular friends, they will do a homework. And so what you're doing is competing activities, constructive activities, things that will compete with it. They do those things at home, they're not doing them outside where they have access to drugs, but also the stimulus control part of it that we talked about with alcoholism, and that is staying away from people who do use drugs and increase the amount of time and activity with the people who don't use the drugs. And then a good part of what the procedure is also in the communication part of the problem, and that is how to ask for things reinforces, and the other, how do you react to something annoying? If there's something that's annoying from one of your peers, which is often the case, or from your parents, how do you react to it in the way we talked about? Remember the understanding statement, which another better way of designating it is actually anger control. And you first calm yourself down, and then speaking, and then reacting in that manner. And so that's one of the principal methods of dealing with youth drug abuse. At the time we worked on that, there was hardly any studies doing with youth drug abuse, right? It was all with adults. And so that was one of the first studies that we had on that. And what we did is adapted the procedure that we could develop with the adults with the youth. Well, let's see, I can't believe I got all this time here. Here, almost time to go. Let's see, there's another thing that I did, and this is not unique to me, but depression. The rampant feeling in the field, the most common feeling method in the field in psychology when we're dealing with depression, what's clinically called major depressive disorder, is cognitive behavior therapy, cognitive restructuring, and teaching individuals not to catastrophize, not to engage in all or none thinking. And so whenever they do start having depressed because some event, now to go into rephrase it, to think about, not rephrase it, that's behavioral. To think about it differently, to reconstruct the cognitions of it. And that's the dominant point of view in the field, and it's almost universally accepted as the principal method and desirable method of doing it. There is another method, and I'm not the first or the only one that has used it, but among those, and there was some initial suggestion by some Optin people that depression may be explained in behavioral reinforcement terms in a rather simplistic way, and that is depression results from the sudden reduction of positive reinforcement or the sudden infusion of aversive stimuli. And that actually follows from the definition. If you look at the clinical definition of major depressive disorder, there are two different types, and one of them is called reactive depression, and the other is called endogenous depression. And reactive depression is where you can identify the cause of it as being some type of trauma. The stock market went down, a loved one was gone, a member of your family died, or a pet, you lost your job. It's some dramatic event, right? Reactive to something. The definition of endogenous depression is much simpler. And that is that you can't find any reaction to some specific event. And so you assume that it's physiological, but that's just a blind guess. Nobody's found any physiological correlates that are that closely associated with depression. So from that point of view, what the behavioral point of view would suggest is if something causes the depression, then why not try to reverse it? And so if your pet dies, get another one. You lost your job, problem. You have trouble with your marriage, behavioral marital counseling. That there are ways of reversing it. You lost money in the stock market, well, invest it somewhere else. Well, And so look at what the causes are of that, and now take actions to reduce it. And also, if the definition of it, like you said in marriage, is very concerned with the absolute, with the frequency of reinforcement, in this case it's the relative frequency, that the frequency was going down, then what it suggests is inserting reinforcements. And so the general phrase that's used to describe that is called behavioral activation. And then start instating, priming, primary enjoyable activities. And concretely, the way to do that is you make up what's called a daily planner. It's the calendar, 7 o'clock, 8 o'clock, 9 o'clock, and try to fill in every possible moment with a pleasurable activity, something that's concrete. Again, concrete and structured. You're going to call up your friends at this time, you're going to go on a date at this other time, you're going to go bowling, you're going to read something and listen to music. But structure the whole day on that. And then the correlates that have been done, if you take correlational approach, then and have the people rate how depressed they are, then of course, while they're engaged in these positive activities, there's no depression. And so it's called behavioral activation. There are some other ways of doing that as well, and I know the procedure that I developed on that and others have them not just engaging in the thing, but in the social part. And so one of the neatest procedures is that every time you meet somebody for the first time during the day, say something nice. Say something positive. Even if it's about the weather or the political situation, or ideally about the other person or about yourself. I feel great. Anyway, say something. You can't be depressed while you're in. It's almost like the case of that habit reversal. If you have a competing response, you can't engage in the tick. If you're doing something positive, you won't be depressed. Well, the hundreds of studies that have been done using the cognitive therapy research, and that seems to correspond to the lay idea of depression, that your problem is thinking. If you stop thinking negatively, then you'll be all right. And so change your thoughts. The behavioral is act positively, and then that'll cause you to think positively too, and you won't be depressed. And so extending that not just to these other general activities, but especially to the social ones, and that is praise, give compliments, every contact that you have with another person. Say something positive. If you're at the checkout counter in the supermarket, compliment the checkout person and how fast they're working and how well they're doing it, and how nice it is that the store is doing so much business, and it's great that you found exactly the exotic items that you were looking for. Say something positive, nothing else. Talk about what a great day it is. If it's a lousy day, then don't talk about that. Say how nice it is to be indoors out in the rain. But say something positive. And there have been actually a couple of head-to-head comparisons of these two methods. And one of them was one of the authors was Neil Jacobson, who's one of the behavioral marital people, and he was one of the authors on that. And the other author was Holland, who was one of the foremost cognitive people. And they did this study and found out both of them were effective, and very substantially effective, and equally effective, and that all of the therapists who were doing it were strongly biased in favor of the cognitive. They needed to be, in fact, when they were assigned, it was the same therapists who were assigned to do both. When they were assigned to go to treat somebody with the behavioral, they moaned and groaned and paradoxically became depressed themselves. So, and yet that procedure ended up being better than, at least as good or better than the other, and much easier, much simpler, because the other cognitive restructuring, you go into talk about underlying axioms and premises, it's complicated beyond belief, talking about these traits in your unconscious motives. This other method is just so easy to do, and that's the method that we use when we're dealing with people with depression. Well, then only two other things that I have. Let's see, 6 minutes, great. And these are two things I did very recently, and they don't have the big studies that were done on them, but I'm really so delighted with them. One of them was the one on ADHD, and the story on that is that I was asked to go to consult in the school that Rome University has for autistic children, and there was one 4-year-old autistic child that was making the special ed class that he was in. were just unbearable, that he was aggressive. So they called me up and asked me if I would do something, and I worked on aggression with some developmentally disabled people. And I said, sure. We went in, I went and looked at him, and it turned out it wasn't aggression at all. It was, he was just all over the place. He was just bouncing around like a loose cannon. And he knocked over chairs, knocked over tables. If it was a person, he knocked over the person, but he wasn't aggressive against them. They were in space. So with hyperactivity, well, okay, one of the treatments for hyperactivity is the token economy. So I decided to use the token economy. What should I use as the reinforcer? Pretty clear what I should use for the response, right? It should be calmness, attentive calmness, because we both have a problem, both ADHD attention and ADHD hyperactivity. And so so that was clear, that was the response, but what is the reinforcer? So I went back to my old friend, the Premack principle. What is the high probability behavior? And preferably, what is the highest probability behavior of this fellow? Anybody?
Running around.
Right, physical activity. Well, when you think about physical activity and ADHD, the usual manner of treating ADHD is, well, let them get it out of their system. Then we'll go out on the playground, then hit a punching bag, right, run around, and get it out of their system. But this way, this is different. The behavioral system, if that's the reinforcer, make it contingent. Contingent on what? On attentive calmness. And so this little fellow who bounces around and could sit on a seat for more than 2-3 seconds, arranged the situation so that when he sat on the seat calmly and looked at you, then he received this reinforcement. We had the thing arranged right next to the door leading to the playground outside. And so whatever it started off with shaping, it started off with 1 second, which meant literally he just sat down before he could think of getting up. He said, wonderful, you're sitting still. And took him outside, and then followed a formula there, and then just give 2 reinforcements at each duration, increase the duration when you do after 2 reinforcements by 50% roughly, which meant 1 second, 2 seconds, 3 seconds, 5 seconds, 7 seconds. Inside 1 hour, he's sitting there as calmly as can be. And the teachers come in and ask him to be grumpy. What do we do? And then we got him into his regular classroom. And so that really was a perversion. You're using the symptom as a reinforcer. The symptom is a reinforcer, right? For the absence of the symptom. Right? But I told you the logic in doing it. After I worked out, I said, no, this can't be. I mean, how in the world can you use, and just to see whether that was the case, that we're in control, and that is giving the reinforcer, the physical activity, not contingent, so that every minute, regardless of what he did, he could go out and play. Then come back, regardless of what he did, went out and played. If dissipating all that energy was the red cure, which is the common belief, it didn't do anything. He didn't average more than 1 or 2 seconds on that seat. The other way, it was just sat there completely. Well, so I was very excited about that, because it just followed conceptually so clearly, and the result, though, totally wonderful. And so I went ahead and went off and said, okay, how can I use that in the classroom? So I got a classroom that had 2 or 3 hyperactive kids in it, kids who were officially hyperactive and others that were just unofficially, and arranged the procedure in the classroom. And there, what it involved is a group contingency, and that is that when the class was attentively calm and did not require more than one, the rule was more than one reminder by the teacher that there was a 5-minute break, one in mid-class and one at the end, and that worked out beautifully. So it's a whole different way this entire, and that's very recent, and even though I only did it with a few people, it's so conceptually so intriguing, yes.
Just real fast, I was going to say that, today they're taking away recess in gym class. It used to be, I know as early as like when I was a kid, that not too long ago, that you could go out and play. That was the big reinforcer, and if everybody was okay, and that's what kept my class in 6th grade all together. I remember the students.
So you can imagine if you made that contingent on good behavior.
Yeah.
I mean, right? they would kill for it, right?
Now they've just taken that away. You can't even, they don't even, the teachers don't even have that.
Well, so that was there was another interesting thing very recently, and again, it's one of these large-scale studies like all the others were, and that was working on bulimia. I don't know if you know what bulimia is, but it's individuals, primarily something that occurs in young women, and it's eating large amount of food that's not too good for you, what they call taboo foods, and there's ice cream, cake, cookies, candy, and then vomiting, usually inducing the vomiting by putting a finger in their throat and doing it in private. Usually their spouse, their family members, their husband, nobody knows about it. It's a closet problem. They don't know about it. Because, and they go to a restaurant and they do that, and then they go to the restroom and be sure to use a closet there and induce it. And they use cognitive therapy. That's the current therapy, and the cognitive restructuring, because they say the reason they're doing it seems very sensible. That if I don't vomit, I'll get fat. So, well, then why eat so good? Well, it tastes so good. and so that seemed to be such a straightforward kind of an explanation of it. And so what you do is cognitive restructuring and try to convince them that they won't get so fat if they vomit. Well, I started working on actually with retarded individuals. I was working with retarded individuals in South Florida. I had some residents there in Jack who engaged in what I guess is best described as projectile vomiting. They self-induced vomiting. It wasn't because they weren't like the bulimics. They weren't doing it to lose weight. If you asked them to do something they didn't like, or you had an activity that they didn't like, they vomited on you. They sought you out, and they vomited on you. And so you never asked them that again. It was a very effective operant. And the first thing I did with that is I tried an overcorrection procedure on it. That is, that what they did, then had them clean it up, and then in positive practice, had them practice going to the stool and bending over and practice the correct way because they could have been stomach upset, and have them practice eliminating things from their stomach that were producing a problem. And so I did that, and that worked. But then I had two more projectile vomiters, and I was about to try something else with them, and then it disappeared. They stopped vomiting. What's wrong? And then examining what the context might have been, it turns out that I had them concurrently engaged in a mealtime training program. And one of the characteristics of the meal, I was teaching them to eat with a knife and a fork and a spoon, and to eat slowly. And one of the things I also had there is I broke each meal down to 3 parts in order to space out the meal. And I thought, well, maybe that's what caused it. Yeah, which part of it? Don't know. It's not eating with a knife and a fork and a spoon. That shouldn't cause it. But maybe it was the eating slowly. So I did a series of studies on those projectile vomiters, and what I did is I tried measuring what their rate was beforehand, and then tried just slowing their speed down, and then went to the other extreme. And gave them all they wanted, in which they just ate it as soon as it appeared on the table. And their rate of vomiting went up so high that the medical staff said that the study had to be discontinued. And so that was pretty clear that was it. So when I had the opportunity to work with, there was a graduate student, and we were going to work on something else, but he said part-time he was working illegally as a graduate student with somebody in private practice, and he had, one of them was a vomiter, was a bulimic. I said, well, maybe this thing would work with them. And so I brought them in. I first did it with one, then I did it with, there were several more. I brought some of them, and I think it was about 6 to 7 altogether. And they, and arranged it, well, the methodology is not important, but ABA, an ABA. The morning meal was slow, the lunch meal, same meal, so it was equating for the food. It was slow and fast, and the last was slow, and then reversed it the next day, BAB. So the whole study took 2 days with each subject, which is the best kind of study to do. It makes doctoral students very happy about their dissertations. Yeah. Well, And enormous difference, and that is no vomiting. Just no vomiting. And what I did is actually, I took a subjective scale to see, had them rate what their urge to vomit was. And in the spaced eating, it was there. So I tried that with several more bulimic individuals who I was able to obtain, and the effect was there for all of them. And so but then what happened is something interesting. One of the bulimics, when they were eating slowly, kept saying, "I'm full. I can't eat anymore. What's going on?" Because conceptually, the reason why you're vomiting is you're eating all of this extra food, you've got this pressure in your stomach, and the same thing with the retarded. That's what I thought they were doing. When you gave them all they wanted to eat, they vomited terribly, so it's pressure in their stomach. When they eat slowly, that gives time for the food, it's the same amount of food, it gives time for the food to pass from their stomach into their intestines, so you get less pressure on their stomach. And no, it didn't make any sense. Does eating slowly make you feel satiated sooner, that you will eat less food, and yet subjectively feel that you have had enough? So, on to the drawing board, right? So I did a study on that. And it was easy to get people who were desirous of losing weight. Went to the school, has a fitness center, and just asked how many people there would like to be in the study. They were trying to get at some of the causes of hunger. And the whole group volunteered. And so we did the study with them, and this time the response that we had was, well, we had two responses. I'll give you the one that we have all the data on. Asked them how satiated were they, subjective, right? So it's behaviorist, and yet I didn't feel like waiting 6 months to find out what the effects of this thing would be. And sure enough, there was something like a 3-to-1 difference. That when they ate slowly, they felt satiated. Same with the equivalent amount of food, not the same amount of time, because when eating slowly, obviously it takes longer. Did that. But then what that suggested is the next step, which is what we're doing now, and that is measuring how much they ate. Give them the meal, eat it slowly, and now let when you're satiated, stop. Forget about the subjective measure, just stop. And so it was real neat. In other words, that's one of these, there are so many measures that, again, that Charles Dick Stewart developed in terms of eating and weight control. But this is a totally different method. And then eat slowly, and you will feel full sooner, and you won't want to eat anymore. So anyhow, those are two very recent things. The one about the hyperactivity and the one about the bulimia and actually the weight reduction. Well, that's it. Getting back to what we started off saying, that this is an incredible array of different problems, right, between bulimia, weight reduction, job finding, marital, the autistic individual, the retarded individual, marital counseling, the depression. And again, that what I started off with, the behavioral model is just such a powerful one. The notion that it deals only with very restricted responses and it's mechanical and doesn't take into account one's emotions or one's values it's antithetical. I just see the other points of view as just being tangential to what we really think should be done. And so it's really very, very exciting. What is the message for you personally? To the extent that you're willing to go to try different problems, the world is open to you. But even if you take some of the problems that have been developed by behaviors, the things that are comorbid with your developmental disability, there's certainly depression and anxiety and the social relations. There certainly are, or employment. Then I think just go for it. It's far more exciting than dealing with just one problem. That you're dealing with, what's that phrase, the whole person. We're dealing with all of the aspects of the person, and that the behavioral model doesn't have any constraints on working on these very complex interpersonal types of issues and interpersonal relationships. I thank you for your kind attention.
Dr. Asselborn, on behalf of everyone gathered here today and our colleagues from Delaware and New Jersey, I want to thank you for sharing your lives and helping others with this.
My pleasure.
The scope is just fascinating and just inspiring.
Thank you. Well, I'm sorry we didn't have a break for questions, but any of you care to ask any questions either while others are present or privately, and I'm here.
And if everybody will remain for a few minutes, Terry Page has some announcements and some homework related to our CEUs that he needs to cover with you guys. All right, wonderful. Thanks.